Boys and girls, good afternoon.
Good afternoon, sir.
Good afternoon, sir.
Say me please, third year students present here now.
Fourth year.
Fourth year.
Fourth year.
Group number 18, present, third year. Group number 3, group 8. Only fourth year, yes?
Yes.
Yes.
Okay, and where is my group third? Okay, Так, okay, boys and girls. So it's 3 o'clock, yes. 3 minutes plus 3. So I think we should start our lecture. Yes. Do you see me? I hope. Today we have first lecture in this semester. And it's lecture about this lecture about anatomo-topographic and physiologic substantiation of formation of hernias and common principles of herniaplasty. Well, the aim of the lecture is to consider anatomical classification and modern conception of genesis of external hernias, weak places of abdominal wall, and also principles of herniaplasty. Tasks of the lecture are actuality, history and stages of studies about hernias, definition of hernia, weak place of abdominal wall, classification of hernia, modern conception of pathogenesis of external hernias, main principles of technique operations in external hernias. Do you hear me? It's all right?
Yes, sir.
Yes.
Great, great. Actuality. Earlier, yearly, in the world, 20 millions of operations in hernias are carried out. That composes from 10 to 15% of all operative interventions. Each third, fourth, fifth inhabitant of the Earth is a potential carrier of hernia. Peak of morbidity is observed in preschool age in people older 50 years. In Russia, yearly about 260,000 of operations are carried out. Recurrence of disease arising each 8/10 of patient, average 10-15 of patients. History of surgery of abdominal hernias. Condon and Nihus said that the history of hernia is history of surgery. At this picture you may see Claude Galen. The first time introduced term hernia. It was many years ago, as you may see. Yes, Claude Galen. First definition gives. Here you may see Cornelius Sales. Cornelius Sales, first century of our days. Yes, Cornelius Sales introduced classical determination of hernias as protrusion viscera through acquired and congenital heals, called them hernia. He suggested method of transillumination of scrotum for differential diagnostic. He opened sac, cut strangulated ring and organ set into abdominal cavity. So he did first herniatomy operation. Yes. Gilliador, 4th century, recommended to use bandages in small hernias in children, carried out operations only in adult in big hernias. It's a bandages you may see of that time. Abdominal hernias history. After the opening of anesthesia, asepsis, antisepsis, of course, it did the seriously progress. Yes. In 19th, 20th century, scientific approach in study different of aspects of herniology. Cooper, Hesselbach, Lagenguck, Bolotsky, Bobrov, and others. The outcome of hernia surgery is very surgeon department dependent. And Astley Cook's quite statement of 1804 is still pertinent and appropriate introduction to this lecture. No disease of the human body belonging to the province of surgeons requires in its treatment a greater combination of accurate anatomical knowledge with surgical skill than hernia in all its varieties. First plastic operation in inguinal hernia was made in 1885 by Championnier in France. In Russia, similar operation Bobrov carried out in 1892 year. Bassini, Postemsky, Spasokukotsky laid basis of modern herniatomy. Definition of hernia. A hernia is defined as a protrusion of a viscera with parietal peritoneum, it's very important, through an opening, natural or artificial, in the musculoponeurotic layers of the abdominal walls under the skin. Clinically, the important point of the definition is the protrusion, because without protrusion viscus, a diagnosis of hernia is essentially impossible. Anatomically, the important features of the hernia are the hernial ring and hernial sac. Classical elements of hernia. Red indicators show that the hernial ring or orifice, it's a weak place for which hernia protrudes. Hernial sac, it's a green indicator showed. Hernial sac, parietal peritoneum. And hernial contained, blue indicator showed. Here it's a loop of small intestine. Hernial ring, defect in the innermost aponeurotic layer of the abdomen, or weak place, we can say. Hernial sac, outpouch of peritoneum, protrusion of parietal peritoneum. The neck of the hernial sac corresponds to the hernial orifice. The size of the hernia is determined by the dimension of the neck and the volume of the sac. A hernia is external if the sac protruded completely through the abdominal wall. A hernia is interparietal if the sac is contained within the abdominal wall. And a hernia is internal if the sac is within the visceral cavity. The hernia is reducible, then the protruded viscus can be returned to the abdomen. The hernia is irreducible, then the protruded viscus cannot be returned to the abdomen. And strangulated hernia is one in which the vascularity of the protruded viscus is compromised, usually at the neck. Strangulation is most likely to occur in hernias that have small orifice and relatively voluminous sacs. Weak places are, by Krimer definition, parts of the abdominal wall devoid of muscles upon neurosis, having muscular and aponeurotic slits, through which the vessels, nerves, anatomical structures may pass. The weak places are umbilical ring, slits in linea alba, inguinal canal, femoral canal, semilunar line of Spigelian, arcuate line of Douglas, inferior lumbar triangle of Petit, superior lumbar triangle of Lesgeld-Greenfield, and the obturator and sciatic foramens of the pelvis and perineum, and maybe postoperative or post-traumatic weak places. Scar, it's a new weak place. At this picture, you may see classification of hernias by anatomical position. Linea alba or epigastric hernia, yes, umbilical hernia, inguinal hernia, this one, femoral hernia, postoperative hernia, incisional hernia, yes, here you may see scar after some operation. Semilunar hernia along Spigelian line, epigastric, umbilical again. Yes, as you may see, the inguinal hernia situated above inguinal ligament, and femoral hernia lies below inguinal ligament. Rare types of hernias, it's hernias, lumbar hernias. This one through triangle petit or petit triangle. This one inferior lumbar triangle, and this one for superior lumbar triangle. It's a Lesgov-Grunfeld triangle. Lesgov-Grunfeld triangle. It's a rare types. Classification of hernia, anatomical classification. It's external hernias maybe and internal. External, inguinal, femoral, umbilical, hernia of linea alba, hernia of semilunar line of Spigelian and arcuate line of Douglas, hernia of xiphoid process, lumbar, hernias, inferior lumbar triangle of Petit, superior lumbar triangle of Lesgov-Grunfeld, hernia of pelvic floor, the obturator and sciatic foramens of the pelvis and perineum, and postoperative post-traumatic hernias. And internal hernias, frequently it's a diaphragmatic hernias. Here, internal hernias demonstrates, you may see, diaphragm, esophagus, stomach, and through esophageal foramen, part of stomach, fundus at this situation may protrude outside from the abdominal cavity and entering thoracic cavity. Part of fundus or all fundus of stomach, yes, at this picture you may see all stomach produced in thoracic cavity from abdominal. Yes, it's all internal hernias. Hernias of the esophageal foramen of the diaphragm. Next classification. Hernia may be congenital and acquired. Hernia may be reducible and irreducible. Uncomplicated and complicated. And acquired hernia may be traumatic and dystrophic. Deep diagnosis. Hernia with eventration and prolapsus. Eventration. It's a protrusion of the organs of the abdominal cavity through suddenly developing or congenital defects of abdominal wall without covering by peritoneum outside. Eventration may be congenital, traumatic, and postoperative. Prolapsus. It's a protrusion of the organs or part of them through natural foramen of its cavity without covering by peritoneum. Prolapsus of the rectum through anus, yes. Prolapsus of the vagina and uterus through vagina. Cavity of the abdomen is limited by superiorly diaphragm, anterolateral by muscles of prelum or press of abdomen, posteriorly by vertebral column and muscles of lumbar region, and inferior by pelvic inlet. The abdominal cavity, it's the biggest cavity of our body. Так, abdominal wall demonstrates with this picture. Muscles of abdominal wall, superficial and middle layers here present. And in this picture, middle layer. So which muscles we have? Lateral group and medial group. Medial, it's rectus muscle, left and right. And laterally, we have three layers of muscles, yes. External oblique abdominis, this one internal oblique abdominis muscle, and beneath it situated transverse abdominis muscle. Clinical term for parts ligament. Muscles of the abdominal wall, abdominis deep layers. It's here demonstrates transverse abdominis muscle. Transverse abdominis muscle. Well, and then aponeurotic layers of each lateral muscles, they cover the rectus muscles and arise the sheath for rectus muscles. Along lateral side of rectus muscle, we have aponeurotic layer. It's a Spigelian line here, one of weak places. Spigelian line. Function of wall: supporting for organs, external respiration, regulation of blood circulation, regulation of intrathoracic and intra-abdominal pressure, motor activity of gastrointestinal tract, movement of trunk, shoulder, girdle, and pelvis. Walls of the abdomen endure big physical efforts. What is 20 minutes now, and students calm and calm. Interesting. Elastic basis of the anterolateral abdominal wall is composed by 3 pairs of flat muscles, lateral group, and pair of rectus abdominis muscle. You may see how the intra-abdominal pressure pressed on the muscles. Yes, maximum is in center. Phenomenon of intra-abdominal pressure is determined by interaction of effort of muscles of abdominal wall, elasticity of flow by blood of parenchymal organs of abdominal cavity, elasticity of peristaltic hollow organs of abdominal cavity, value of pressure 15 till 230 millimeters mercury column. Physiological importance of intra-abdominal pressure. Intra-abdominal pressure provides fixation of abdominal organs in defined position. It is known, for example, that in weakening of muscular tension with ages, enteroptosis, partial or total is developed. Intra-abdominal pressure promotes to maintenance of normal function of abdominal organs, makes more active blood and lymph circulation in the abdominal cavity. Positive role of intra-abdominal pressure is provided by dynamical balance of value of muscular tension and intra-abdominal pressure. In prolonged increase of pressure and decreased mechanical durability of the abdominal wall will occur formation of hernia. Hernias of the abdominal wall occur only in areas where aponeurosis and fascia are devoid of the protecting support of striated muscle. Factors of hernia formation. Productive. It's increase of intra-abdominal pressure, work, weeping, crying, delivery, constipation, cough, heredity. And predisposed. Weak place of the abdominal wall, everyone here. Peculiarities of constitution, type, sexual and age differences. Changes in the abdominal wall with ages. Connecting with pregnancy. Unfavorable conditions of work and mode. And pathologic states.
What does it mean by sexual? Sexual like intercourse?
No, it means that, for example, inguinal hernias frequently has males and opposite femoral hernias frequently has females because different structure of pelvis. Yes.
Yes.
Weak places may be divided in canals, it's inguinal and femoral canal, foramina and slits in linea alba, and slits and aponeurosis of external oblique, internal oblique, and transverse abdominal muscle. Inguinal hernia takes 3–4% of population carried of hernia. In USA, yearly 700,000 operations are carried out in inguinal hernias. The groin inguinal is one of the natural weak areas in the abdominal wall, and it is most common site for abdominal herniation. Well, and this picture demonstrates, yes, the boy with inguinal scrotal hernia, yes, then inguinal hernia enters in scrotum. So we may say that it's what? Which inguinal hernia? It's an oblique inguinal hernia, yes. Then, at this situation, patient with inguinal scrotal hernia in standing position. Let me see. As I see, this one has from both sides. Yes. Here and here. Giant inguinal hernia, look, so big. Till knees, yes. The scrotum, downward till knee. Why this patient so many years sitting at home, I don't know. The canals of the abdominal wall are the most weak places of the abdominal wall. No, why? First, they are constant. Yes, everyone has canals, inguinal canals. Presence into canals of large anatomical structures. And it's prepared through the effect of the abdominal wall for formation of hernia. With this picture, what we can see it's a boy, yes, it's a spermatic cord follows, which exit from the inguinal canal. Inguinal hernias pass through inguinal canal and compose 63–90% of all hernias of abdomen. It takes first place. Both sexes of all ages are afflicted. But men are 25 times more likely to have an inguinal hernia than women. The estimated incidence of inguinal hernias in men is 3%, thus making hernias a major economic problem. Inguinal hernia in women, a rare situation, but here we may see protrusion through inguinal canal. Inguinal canal structure. At this picture you may see the opening of inguinal canal, yes, anterior wall on forceps. It's aponeurosis of external oblique muscle. Yeah. And this superiorly, it's a transverse muscle. Here you may see the spermatic cord, superficial, number 9, yes, it's a superficial inguinal ring. No, at this area, situated deep inguinal ring. It's abdominal wall from inside, if you look from inside, yes. Here we have umbilical folds. Between them we have fossa, supravesical fossa, medial inguinal fossa, and lateral inguinal fossa. Prolateral follows spermatic cord. Same for lateral fossa may enter and inguinal hernia. It will be oblique inguinal hernia. For medial inguinal fossa may produce direct inguinal hernia. Oblique inguinal hernia will go along spermatic cord, and with spermatic cord it may enter in scrotum. Direct inguinal hernia cannot enter in scrotum. Inguinal canal deep rings again here demonstrates bladder, calls deep inguinal ring. It's the same as a lateral inguinal fossa. If hernia produced here, we called it deep inguinal ring now. Inguinal canal in pathology. Under 34 years, superficial inguinal rings increase, especially in men older 60 years. Size, especially in size of deep ring with age increase. 15–17% of high inguinal interval is observed, and deep ring is not covered by muscles. In 26% is partially covered, and in 57% inferior margin of muscle completely covers deep ring. At this picture, you may see the examination, yes, manual examination, comparative palpation of spermatic cord. Here palpation of superficial inguinal ring when we take our second finger and indices and put it in area, same as here demonstrates. Superficial ring palpation by fifth finger, yes, here by second, here by fifth. Well, doctor puts his finger in area of superficial inguinal ring and ask patient to have cough. Then patient have cough, yes, few times. Intra-abdominal pressure increase at this moment, and doctor by his finger may feel the protrusion in cough moment. Yes, he may feel the protrusion of hernia. Inguinal interval, boys and girls. What is it? Inguinal interval, it's a distance between inferior and superior walls of inguinal canal. Inferior wall of inguinal canal, it's a inguinal ligament. Here. Superior wall, it's a transverse muscle in pathology. If patient has hernia. Without hernia, superior wall, it's a transverse muscle and free margin of the internal oblique muscle. So this distance, you may see these two different pictures. Yes, here short distance we have between inferior and superior wall, and here distance is so big. Of course, the patient which has big distance, inguinal interval, has higher risk to have inguinal hernia. Yes, if interval is short, risk is lower. In 32% of men and 14% of women, inferior fibers of internal oblique muscle pass horizontally above spermatic cord, and arch is only formed by inferior margin of transverse abdominal muscle, or both muscles pass horizontally. In triangle shaped of inguinal interval, the shooter mechanism is absent. Yes, interval may have few shapes, triangular shape, yes, as here, triangular shape. It may be oval, as here, and it may be round, And if it's triangular shape, the shooter mechanism is absent. Shooter mechanism demonstrates here, for example, this. Well, shooter mechanism of the transverse muscle, transverse fibers of transverse muscle, which closed the interval. Transverse fascia in 33% is reinforced by muscular and tendinous fibers. Transverse fascia is reinforced by tendinous fibers from internal oblique, transverse, and rectus abdominis muscles. The medial part of transverse fascia is reinforced by formation of the conjoint tendon, inguinal falx or Henle's ligament. It's here. The merging of the pubic attachments or the internal oblique and transverse abdominal aponeurosis into a common tendon. Hasselbach interfoveolar ligament, it's blue column. This. The lateral part of the transverse fascia is reinforced. Schema of shooter mechanism of deep ring and inguinal interval. In oval and slit-shaped inguinal interval, musculoponeurotic structures form the shooter mechanism. The internal oblique abdominal muscle covers the deep ring and forms the shooter mechanism. Then muscular contraction retracts the Hasselbach interfoveolar ligament and complements the shooter action of the internal oblique abdominal muscle by pulling the cord at the deep ring laterally and superiorly. Inguinal hernias. Carried of hernias is 3–4% of population. It may be indirect or oblique hernia, inguinal hernia, congenital maybe, and acquired. The sac of an indirect inguinal hernia passes obliquely toward the end, ultimately into the scrotum. And direct inguinal hernia. The sac of a direct hernia protrudes directly outward and forward, and maybe sliding hernia. So, indirect maybe congenital and acquired. Direct, it's always only acquired hernia. Congenital indirect inguinal hernia. With this picture, you may see the phases of testis descending. Processus vaginalis is not overgrown. Processus vaginalis is partially overgrown and hydrocele and hernia are may form. Processus vaginalis is not overgrown at deep inguinal ring and it's obliterated on separate parts. Hernia and cyst of spermatocord are formed. Normally, as you remember, testis situated under the kidney in fetal period, and then it goes downward. It's called descending of testis. Then finally, testis enters in scrotum and takes with it the peritoneum layer. And peritoneum layer which covers testis called tunica vaginalis. Normally, the tunica vaginalis cavity and peritoneal cavity, between them should be obliteration. It's a normal. But if it's not obliterated, they have community. In this situation, patient may have congenital inguinal hernia. Congenital inguinal hernia. Sometimes obliteration goes partially. If it's partially, patient may have different problems, hydrocele, or cysts. Так, one moment, please wait. let's continue. Yes. So, and if it's partially obliterated, it's maybe here formation or spermatic cord, maybe formation of the different cysts. Congenital indirect inguinal hernia. This situation possible to have, yes, then community between tunica vaginalis and peritoneal cavity is present. Yes, and that this picture demonstrates hernia. Protrudes through lateral inguinal fossa or enters deep inguinal ring. Hernial sac is formed by process vaginalis and is covered by all three facial coverings of the spermatic cord. So hernia will situate it under the sheets of spermatic cord. Okay. Then transverses enter inguinal canal, exits through the superficial inguinal ring, and commonly enters the scrotum. May enter in scrotum. Acquired indirect inguinal hernia demonstrates here it's a spermatic cord. Sheets of spermatic cord we open on forceps, and we may see the hernia. This blue color, it's a peritoneum, so hernial sac, yes. And inside we may see this white color, it's a intestine, loop of intestine. It demonstrates mechanism: protrusion in sagittal plane, yes, protrusion for weak place, entrance in canal, then through superficial inguinal ring, exit in subcutaneous tissue, and then enters into the scrotum. Now it's inguinoscrotal hernia. Acquired indirect inguinal hernia. Here demonstrates different patients. It's a baby, yes. It's adult patients with big inguinal hernias, inguinoscrotal hernias, yes, here. Acquired indirect inguinal hernia. It's produced through lateral inguinal fossa or enters deep inguinal ring. Transverses enter inguinal canal anterolaterally to spermatic cord. Exits through the superficial inguinal ring and commonly enters the scrotum. What is the difference, main difference, boys and girls, in congenital and acquired inguinal hernia? If it's congenital inguinal hernia, the hernial sac, it's a tunica vaginalis and testis part of hernial sac. If it's acquired indirect inguinal hernia, the hernial sac, it's just parietal peritoneum layer, not tunica vaginalis. Yes, it's a main difference. Direct inguinal hernia demonstrates at this picture. Here, spermatic cord laterally from hernial sac. It's a hernial sac, and inside loop of intestine is hernial container. So, direct inguinal hernia protrudes through medial inguinal fossa. Indirect through lateral, direct through medial inguinal fossa. Passes through inguinal interval, lies outside the spermatic cord medially to it. Doesn't travels the entire inguinal canal, usually only its most medial part, lower end, and adjacent to the superficial inguinal ring. Almost never enters the scrotum. Clinically distinguished and an indirect form and direct inguinal hernia is often impossible. So before operation, we cannot say it's direct or indirect, only intra-operation. We can put final diagnosis. Sliding hernia, 0.6 till 3.9% takes. One of wall of hernial sac is formed by visceral peritoneum covering of sliding hollow organ. This organ is mesoperitoneum. This picture demonstrates sliding hernia. What is here? It's a urinary bladder which covers mesoperitoneum. It's a loop of intestine. Blue line, it's a parietal peritoneum. Here, orify, weak place for which loop of intestine produced through abdominal wall. So it's produced parietal peritoneum, and then parietal peritoneum goes outside. It pull the wall of whole organ. At this situation, it's a urinary bladder wall. Why it goes with it? Because it sliding hernia, yes? Why it may slide? Because it lies on fat tissue. That's why wall may slide and enter as a part of hernial sac. It goes through the weak place. So hernial sac here, it's a parietal peritoneum and wall of organ, wall of urinary bladder. This condition may present both in indirect and direct inguinal hernia. Some or all of the hernial contents lies outside the peritoneal sac. A part of the colon, which is divided of mesentery, the cecum and ascending colon on the right, the pelvic and descending colon on the left side, or a portion of the bladder, urinary bladder, is found to be incorporated in the posterior wall of the sac. Main states of herniatomy. First, it's a removal of the sac, hernial sac, and second stage, it's a reconstructive procedure, repair of defect, weak place, for prevent recurrent hernia. Removal of the sac. Application of hydropreparation and gauze dissection for release of sac from surrounding tissue up to its neck. Sac is opened, that is fundus. Exploration of the sac. The neck of sac is freed from the margins of ring and ligated by transfixion or by pore stream suture at the highest position, possible point, and it's cut off, and then hemostasis. It's a first stage, removal of the sac. Operations in inguinal hernias. They are determined by degree of destruction of posterior wall of inguinal canal and degree of destruction of deep inguinal ring. Autoplastic methods we have strengthening of anterior wall of inguinal canal by common tissues. It's a Gerard-Spasokukotsky methods, Martinov and Ru-Opel. Strengthening of posterior wall of inguinal canal, Bassini, Kukujanov, Sholdais, Postemsky methods. And prosthetics methods by the onlay mesh, synthetic mesh prosthesis. It's 3-tension plastic surgery of inguinal in hernias. For example, Liechtenstein method. Operations in inguinal hernias, classical herniaplasty. Autoplastic methods, strengthening of anterior wall of inguinal canal and strengthening of posterior wall of inguinal canal. So if it's indirect inguinal hernia, we should strengthen or protect the anterior wall of inguinal canal. If it's direct inguinal hernia, we should protect or strengthen posterior wall of inguinal canal. Tension is the principal cause of failure of all the hernioplasties. that close the walls and wings by aponeurotic approximation. Well, this picture demonstrates the different types of operation, sutures. Well, in classes, in practical classes with teacher, you will about every method which demonstrates here, you will talk. By shoulders, operation of shoulders. What is? Advantages of multi-layer plastic reconstruction are evaluated. In long-term period, up to 3 years, recurrence they are seen in 0.5 to 1%. This is 10 times less than in plastic surgeries of anterior wall of inguinal canal. Multi-layer plastic reconstruction is particularly indicated for patients over 40 years with long anamnesis, weak tendinous structures, severe destruction of the posterior wall. This surgery is universal, can be performed in elective and urgent situation. Recurrent hernia. At this situation you may see the scar. Well, this patient had a hernia, then had operation about hernia, and now at same place patient has again protrusion. It's a recurrent hernia called recurrent hernia. And for herniaplasty here, for example, demonstrates the mesh, a special synthetic material. Yes, it has 2 layers here, for example. It's special for umbilical herniatomy. One layer will go under the aponeurosis and another layer will lies on aponeurosis. So we protect and we put it and sublay and onlay for umbilical ring. And the prosthesis by the onlay mesh, synthetic mesh prosthesis. Synthetic mesh prosthesis currently play a major role in the management of hernias of the groin. In general, prosthesis repairs are received for patients at high risk for recurrence after a classical herniaplasty. The most prominent example is recurrent hernias, but their routing use in primary hernia repairs is increasingly common. Synthetic mesh prostheses are used to reinforce a classical repair and to replace the transversalis fascia. Okay, you may see it's a inguinal hernia again, yes. On the holder here situated the spermatic cord, and this is the mesh. It's a mesh. These blue points, it's sutures. Stitch the mesh around the canal, yes, to superior wall, to inferior wall, tuberculum pubicum. By mesh, we may, in inguinal hernias, we may protect strength immediately and anterior wall laterally, yes, and posterior wall medially. No, opposite, laterally, medially. This lateral side, here medial side, in this situation. Only mesh, yes, again, it's an inguinal hernia demonstrates on holder, spermatic cord, and mesh. Mesh you may see here. Liechtenstein operation, it's operation where we use mesh, synthetic mesh. Here demonstrates a fixation of onlay mesh by continuous suture to inguinal ligament. So inguinal ligament goes and mesh stitch to it. Then cutting of the onlay mesh and spermatic cord is positioned between the tails here, in the tails of the onlay mesh. It's a spermatic cord goes, it's a tails of the mesh. Then mesh is fixed to internal muscle and deep layer of rectus sheath by interrupted sutures, or to superior wall stitched of canal. And finally, superior tail of the only mesh is fixated above of deep ring to the inguinal ligament by two interrupted sutures. Here in this hole, in this foramen, yes, you should be very careful. Then you put last two sutures between tails, because you may compress the spermatic cord. When you put the last suture, between suture and spermatic cord should be distant half centimeter for prevent compression of spermatic cord. Operations in sliding hernias. Of course, here we cannot remove the hernial sac. Yes. Why? Because we said that hernial sac presents by parietal peritoneum and part of the organ, wall of organ, for example, or as here it's a sacrum. So, method according to the Zemker and Zimmermann is removing of the three portion of the sac below the attached viscus. Method according to Welton, this one. U-shaped incision is made in the peritoneum at a distance of about 2 cm from the bowel. So that a finger of peritoneum fringe peritoneum remains on each side and is carried upwards beyond the neck of the sac. The bowel is then elevated. Its retroperitoneal surface is covered by stitching together the peritoneal fringes on each side. The bowel, which has been freed from the sac and reperitonized, is replaced within the abdominal cavity. The neck of the sac is closed by a porcine suture and the rest of the sac cut away. Femoral hernias, next type of hernias, it's a femoral hernias. Femoral hernias protrude through femoral canal. Takes 5 to 8% from all hernias. They occur occasionally in women, especially older women. Why it's happen? Because wider pelvis. If pelvis wider, deep ring of femoral canal is wider, more than 1.8 centimeters. In projection of ring muscles, aponeurosis ligaments are absent. I hope you remember from previous semester, yes, it's a type. And we talked about lacunas, lacuna musculorum, lacuna vasorum. And in lacuna vasorum medial side, we have deep femoral ring. Deep femoral. Here it's situated medially from femoral vein, yes, and below from inguinal ligament. If you're looking from type position, here muscular lacuna, here vascular lacuna. It's an artery, it's a vein, and medially from vein, free place. And normally, actually, here situated the lymph node, Rosenmüller-Pirogov lymph node, and surrounded loose connective tissue. But from abdominal wall area, here we have deep femoral ring. which has projection at this place. Femoral hernia demonstrates. As you may see, it's below inguinal ligament. It's a inguinal fold, you may see, yes. And protrusion situated below. It means that it's femoral hernia. It's a woman. Hernial sac. Opening of hernial sac. Yes, it's an inguinal ligament. It's a femoral vein here. Medially from it, femoral hernia. So the sac descends through the femoral ring into femoral canal and turns forward through the saphenous opening, the cribriform fascia, which covers the opening, being thinned out in front of it. Femoral hernias almost always appear as an irreducible mass about the size of a walnut at the medial basis of Scarpa's femoral triangle. A femoral hernia appears irreducible, even though the sac may be empty because fat and lymph nodes from the femoral canal surround the sac. Solitary enlarged lymph node or a synovial cyst may mimic a femoral hernia exactly. The infrequent reducible femoral hernia may be confused with a saphenous larynx. You should know how to conduct diagnosis. Operations in femoral hernias. Femoral methods. It's a Bassini method of repair. And inguinal methods. It's a Ruggi, Reich, and Ruggi-Prolavecio method. Combined method. And this picture demonstrates different types of accesses, yes. Through inguinal canal, for example, green. Other through thigh, yes. It's maybe parallel to, below and parallel to inguinal ligament. It's maybe vertical incision, or a little oblique incision. Strangulated hernia. Strangulated hernia takes 58% of inguinal hernias. A strangulated hernia is one in which the vascularity of the protruded viscus is compromised, usually at the neck. Why neck? Because it's a narrowest place of hernial sac. Neck situated in the area of orify, yes, and if muscles constricts, maybe strangulation. The contents of the sac are constricted at hernial rim. In this situation, the urgent operation is indicated. Urgent operation, yes. In Russia, for example, if you put diagnosis strangulated hernia, you have 2 hours to prepare your patient and start to do operation. And this picture demonstrates different situations, different types of strangulation, yes. It's so-called retrograde strangulation. Then in hernial sac you see 2 normal loops, but third loop, which enters in abdomen, situated in abdominal cavity, is strangulated and necrosis. And at this situation, you may see that hernial content, it's a wall, part of wall of intestine, not loop, yes, just wall of intestine. And if it's strangulated, it's central strangulation called. It's earlier maybe perforation, yes, perforation of the wall, and contained of intestine immediately enters in peritoneal cavity, and patient will have peritonitis. Operation in strangulated hernia, complicated by phlegmon of hernial sac. First stage of operation, it's laparotomy, resection, application of anastomosis. So, if it's phlegmon hernial sac, Of course, we will not open it for to do resection for this contaminated place. Yes, we should do new opening, laparotomy, enter inside, find the place of hernia from inside, hernial sac from internal position, resect this part and put anastomosis. And then second stage, it's an ablation necrotic intestinal loop through inguinal incision. No, if it's inguinal hernia, да? After resection and anastomosis, we stitch laparotomic foramen and go to protrusion place, do the incision, clean all this area because it's phlegmon here, yes, and take out the necrotic intestinal loop. Operation on strangulated hernia demonstrates here. Resection we should do, yes. No, all of you will have topics about operations, about resections of intestine. We will look how to do it. It's a necrotic loop, you may see here. Yes, firstly we should do mobilization of this loop. Mobilization, what does it mean? Then we cut mesenterium from the organ, yes, from the organ. Before I remove the organ, part of organ, we should do the mobilization. So we prevent blood nerve supply of this part, You may see here mobilization, yes, of this part. Strangulated hernia, different types. Here demonstrates elastic strangulation. This one, fecal strangulation, because fecal masses comes to the orifice area and stop here. That's all. If they stop, they compress the vessels in mesenterium. Yes, here. Well, Richter's hernial or strangulation of the wall of the intestine. Richter strangulation. Types of strangulation, it's V strangulation, this one double V strangulation, and retrograde strangulation of loop, retrograde strangulation. Then a loop of bowel is involved in the constriction. Intestinal obstruction is also present, except possibility in the case of Richter's hernia. Richter's hernia is a hernia in which the contents of the sac consist of only one side of the wall of the intestine, always anti-mesenteric, opposite from mesenteric line, yes. Retrograde strangulation of loop of intestine. Now again, we look at this picture. What has happened? Look, loop of intestine enters in hernial sac, then it goes back, again form the loop, again enters in sac, and then goes back. And if it's happened strangulation in this weak place, neck area, the blood supply prevents this loop which present inside. Very seriously situation, boys and girls, because sometimes surgeon may mistake, don't find this strangulation. Why? Doctor open the sac here and find two loops. Examine them, they are normal color, vessels pulsates, and doctor put them back in abdominal cavity and stitch the, repair the orifice. But this loop which inside strangulated, and after a few hours, maybe days, it will be necrotization, perforation, peritonitis. How to prevent this mistake? If you open the hernial sac and find there contained more than one loop of intestine, you should pull all this loop outside and have one big loop. if you start to pull this loop on yourself, of course, this strangulated part will go outside through the orifice. And you will find that it's strangulation, it's necrosis. Richter's hernia or strangulation on the wall of the intestine. Strangulated Richter's types femoral hernias occur relatively frequently and carry a significant morbidity and mortality. The diagnosis of such strangulated femoral hernias is invariable delayed because they present without intestinal obstruction and with minimal local manifestation until the intraoperative nucle of small bowel is gangrenous. Yes, really, here, not so big protrusion, yes, and then doctor palpates this place. Doctor feel no protrusion, cannot see, feel protrusion, yes, because it's small hernia, just wall of intestine, it's a hernial content. Well, that's why sometimes so difficult to put diagnosis and in time understand that it's Richter's strangulation. Laparoscopic hernial repair. At these pictures you may see how to do, where to do foramens for laparoscopic operations in inguinal hernia, for example. Pupart ligament, yes, it's an inguinal hernia. Well, and laparoscopic 3 manipulators. Same by laparoscopic operation. From inside we may put the mesh. It will be sublay, yes, because we put it under the aponeurotic layer. Transabdominal, preperitoneal, inguinal, and femoral hernioplasty. Transabdominal, preperitoneal, inguinal, and femoral hernioplasty demonstrates here. It's a position of foramen for trocar and anterior abdominal wall, on anterior abdominal wall. Then here demonstrates incision of peritoneum for separation of inferior flap separation. Then in lower pictures, peritoneal flap is separated and hernial sac is removed. Peritoneum way is here, flap, yes, hernial sac removed. And now we should put mesh. By mesh explained, inguinal region is closed. It's a mesh. Then at this picture demonstrates how to fix the mesh. Yes, fixation of mesh explained by staples above external iliac vessels, testicular vessels, and inferior epigastric vessels. By special instrument, by staples, we fixate it. And finally, clipping on margins of defect of peritoneum. We put peritoneal flap back. And now mesh situated between muscles and peritoneum, sublay. Transabdominal extraperitoneal hernioplasty. Extraperitoneal. Here demonstrates the position of trocar on anterior abdominal wall, and at this side we may see the drawing of trocar through incision under umbilicus with balloon dissector in extra or preperitoneal space for separation of peritoneum. It's a urinary bladder, symphysis exposition, да? Trocar. Linea alba, one more we place. The fibers of the anterior and posterior layers of the rectus sheath, which is formed by aponeurosis of flat muscles, interplace in the anterior median line to form the complex linea alba. So what happened? The lateral muscles, aponeurotic layers, covered the rectus muscles, left and right, and connect along midline. Along midline, these aponeurotic layers connect, splits, attach, yes, and arise linea alba. Linea alba is a fibrous band running vertically the entire length of the anterior abdominal wall and receives the attachments of the oblique and transverse abdominal muscles. This tendinous raphe is narrow inferior to umbilicus and wider superior to it. Then, superiorly from umbilicus, it's not simply wider in frontal plane, it's in sagittal plane, the retin. And below umbilicus, it's narrow in frontal plane and thick in sagittal plane. So, as you may understand, frequently hernia formation goes above umbilicus to linea alba, because here it's wide and thin. It is always wider in women. With age, linea alba widen older 50-60 years. In 20% of people in wide of linea alba, slits-like spaces with size till 1.5 centimeter are present. In 16% of cases, extraperitoneal lipoma is absorbed. No, this lipoma is a prehernia formation. Places of protrusion of preperitoneal lipoma and hernia through slit-like spaces of linea alba of abdomen. Here demonstrates extraperitoneal lipoma. Preperitoneal, sorry. Here preperitoneal. Aponeurotic hernias. Peculiarities of pathogenesis, unit 10. Hernias of linea alba, diastasis of rectus abdominal muscles, umbilical hernia, trocar's hernia. In pathogenesis of hernias condition of rectus abdominal muscles play a role. That is discrepancy between mechanical load on abdominal wall and possibilities of rectus muscles. When diastasis is possible to have between rectus muscles, boys and girls? If your anterior abdominal wall is very big and large in size, then, for example, in males, yes, if you drink many beer, it's maybe happen. In females, frequently it's after delivery. After delivery, yes, maybe big diastasis. Changes of linea alba and rectus abdominis muscles in pregnancy. This is 12 weeks of pregnancy. Here, 40 weeks. You may see big diastasis. Yes, linea very large here between muscles. And it's 6 months after delivery. Look, before, no, 12 weeks, not so many years, and after. Muscles, boys and girls, after delivery, they can what? It's a fibers, yes, muscle. They can constrict, but linea alba it's a connective tissue. The fibers of linea alba cannot constrict and go normal as before pregnancy. Yes, that's why unfortunately after delivery the linea alba in female's body, linea alba is wider now, and women of course have higher risk to have hernia of linea alba. Forms of linea alba and the rectus abdominis muscles. Yes, it may have different shape, different form. Distribution force acting on linea alba. It leads to diastasis, formation of hernias of linea alba and umbilical hernias. Yes. Again, we may see that the lateral muscles, when they constrict, what happened? They pull the rectus muscles laterally. Yes, and in center we have only linea alba, and all intra-abdominal pressure goes in center. It's an epigastric hernias pass through stage of extraperitoneal lipoma. We may see here. What is? It's a skin, subcutaneous tissue, muscular layer. Here, orify. This red line, it's a fascia, transverse fascia. And after transverse fascia goes preperitoneal or extraperitoneal fat. This is extraperitoneal fat layer. Then it's blue or green color, I don't know. It's a parietal peritoneum. And it's a greater omentum. So first may go protrusion of fascia with fat. Fascia with fat, yes, protrusion goes. And then after them goes protrusion of parietal peritoneum, you may see, yes, protrusion. Oh, and finally, in sac, peritoneal sac, enters the greater omentum as a contained, hernial contained. Umbilical region, umbilical hernias. It's 3-5 till 11% from external hernias of abdomen. It's an umbilical ring, yes, and structures which passes through it, cord elements. The umbilicus is one of weak areas of the abdomen and a common site of herniation. Umbilical hernias occur more frequently in women. Obesity and repeated pregnancies are common precursors, and ascites always exacerbate the problem. Umbilical hernia is adult, are acquired, and have no relationship to umbilical hernia in children. Which structures here, boys and girls? Yes, umbilical vein, which after obliteration transforms in round ligament of the liver, yes, and three structures goes downward. It's two arteries, umbilical arteries, which transforms in umbilical ligaments, medial umbilical ligaments, and between them, number 5, it's a uraphus connecting with urinary bladder. After born, it obliterates and transforms in median umbilical ligament. Umbilical hernias demonstrates these pictures. Strangulation of the colon and omentum is fairly common. Umbilical hernia are common in infants and close spontaneously without special treatment if the aponeurotic defect is 1.5 cm or less. However, repair is indicated in infants with hernial defects greater than 2 cm in diameter and in all children with umbilical hernia still present by age of 3 or 4 years. It's a small hernia. Yes. Methods of herniotomy in umbilical hernias and hernias of linea alba. We may use Lexer operation, Sapeshka operation, Mayo operation, and repair by prosthetic, synthetic mesh prosthesis. And this picture demonstrates Lexer operation when we, after herniotomy, removal of set. Yes, we around umbilical ring put Burstrom suture, tighten it, and then duplication of aponeurosis. We above first layer we stitch it by interrupted sutures. By sapeshka, if you want to do operation, incision should go vertical, and if major, incision should go horizontal. And there we do separation of aponeurosis, one of layer, upper or left, right layer if by sapeshka, and then stitch one aponeurotic layer under another. So we do duplication. Here demonstrates this one, sapeshka method. Yes, we separate one layer aponeurosis stitch under the another layer, and then this layer put on it overlapping. Yes, and here major horizontal incision, and lower flap we stitch under the upper flap. So again duplication. Umbilical hernia operation, incision of skin and section of cutaneous flap. If it's big hernia, we should by ellipse cut the skin. Yes. No, it's a major, again, major operation demonstrates. Hernia to me, an umbilical hernia. Yes, it's a small hernia, as you may see. This is hernia. Herniaplasty in umbilical hernia on major, again, horizontal incision and duplication of layers. Spigelian line hernias. Spigelian hernias are ventral hernias occurring along the subumbilical portions of Spigelian semilunar line. Spigelian hernias are rare and unless large are difficult to diagnose because they are interparietal and contained by the aponeurosis of the external oblique muscle. Sonograms and computerized tomography often reveal symptomatic Spigelian hernias too small to detect clinically. This one, as you may see, it's an interparietal. Yes, it's a Spigelian line area. Here, hernia is situated under the aponeurosis. One layer is produced, another layer not. Oh, it's a full hernia. Yes, it goes under the skin. Under the skin. Spigelian hernia again demonstrates these types. Large Spigelian hernia may be confused for sarcomas of the abdominal wall. Entrapped anterior cutaneous nerves of T10 to T12 produce discomfort resembling Spigelian herniation. Below the umbilicus, the fibers of Spigelian fascia, the fused aponeurosis of internal oblique and the transverse abdominal muscle may split, permitting the peritoneum and extraperitoneal head to protrude through a slit-like defects, 316 millimeters, but to be retained by the overlaying aponeurosis of the external oblique abdominal muscle. Surgical anatomy of Spigelian semilunar line. First one, it's a Spigelian line here, semilunar, linea semilunaris. Second, it's a linea semicircularis, or Douglas line, yes. Third one, it's a vagina musculus rectus abdominis, anterior layer of vagina. And fourth, it's a fascia transversalis. Spigelian hernia demonstrates two-side Spigelian hernia called by Wolstein here, one side and another side. Reconstructive procedure, closing of hernial ring. Yes, we have so simple methods. It's a Lexer, Roux-Opel, Bassini method for common tissues. Reconstructive methods are directed on change of structure of hernial ring. It's a Girard-Spasutkovsky, Martinov, Bassini, Kukujanov, Sholdais, Postemsky, Sapeshko, Medio methods. And plastic when proper tissue is not enough. It's a synthetic mesh prothesis method by Liechtenstein, for example. That's all, boys and girls. Thank you for your attention. Our lecture is finished. You may be free.
До свидания.
Goodbye.
Thank you, sir.
До
Goodbye,
свидания.
sir. Goodbye.
भाग भोसड़ी आंधी आई
Спасибо, до свидания.